Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition. I'm your moderator and narrator, Uriel Riley. Happy Friday. Happy birthday to my nephew, Jeremiah. We are in the 8-8 portal. It's been unlocked. Yes, we have to give thanks. I'm so grateful and thankful for all my friends and family. So we pick up. This is good, right? Peace, everyone. Okay, so we pick up at the middle of page 66. Highest heart love, blissful blessings, Coco Elo Shun. We're in the 8-8 portal. Yes, and today is Jeremiah's birthday. Yesterday was my dad's. Today is my nephew's, my sister's son. So this is a beautiful, beautiful portal opened up, ready for us to release and receive. All right, here we go. Minimal requirements. In the middle of page 66. In general, the requirements for bedside spirometry are: 1. The test must be simple for the patient to perform. 2. The test must be able to reliably distinguish normal from abnormal results within ranges of clinical significance. 3. The system must be portable to allow bedside testing. And 4. The test must minimally provide the force vital capacity, force expiratory volume in 1 and 3 seconds, peak expiratory flow rate, and or maximum mid-expiratory flow rate. Ideally, the technique should provide a printed graph of the force expiratory curve for later study and documentation. The technician performing the study must be well trained in maintaining and calibrating the equipment as well as properly performing the test. It is important that the patient be properly instructed to expend maximal effort and that the level of cooperation be noted and evaluated by the technician. At least 3 separate tests should be performed with the best of the 3 then used to represent the study. Interpretation. In respiratory care, abnormal spirometric studies are generally categorized as restrictive or obstructive abnormalities. A restrictive abnormality, restrictive component, implies a condition in which inspiratory capability is restricted to less than the predicted normal. This must be distinguished from the diagnosis of restrictive disease, which necessitates the measurement of reduced total lung capacity. Restrictive components are diagnosed by the presence of a reduced forced vital capacity in the presence of normal expiratory flow rates. Peace, highs, heart, love. Oh, thank you for being here, Thanos. Clinical application of respiratory care. This is the part of YouTube where we bring peace and master level books of reading and we learn from masters. So this is anyone preparing for the MCAT would this is the information for it. Thank you so much. Yes, we're in chapter 3, the mechanics of ventilation. An obstructive abnormality, obstructive component, implies airway obstruction. This is characterized by a reduction in expiratory flow rates. This condition must be distinguished from obstructive disease, in which the diagnosis necessitates the measurement of an increased total lung capacity. The spirometric parameters generally used to interpret obstructive components are 1. The presence of reduced force expiratory volumes in 1 second. 2. Reduced maximum mid-force expiratory flow rates. And 3. Reduced peak expiratory flow rates. And 4. Reduced forced vital capacity in severe obstructive disease. There still exists a great deal of controversy concerning the application of the expiratory spirogram in respiratory care. For example, there are those who feel the most helpful measurement in delineating the patient's ability to cough adequately is the forced vital capacity, whereas others feel that the peak expiratory flow rate is the most useful single test for this purpose. Our experience has shown the FVC to be the most useful and reliable measurement. Although the use of screening pulmonary function studies seem well founded in clinical practice, their use at present in generally is generally limited. This is most likely due to lack of knowledge about the appropriate use and application. In general, spirometric pulmonary function testing can be used to 1. Provide information concerning any functional impairment that may be present in the pulmonary system. 2. Provide a baseline study for surgical patients. And 3. Provide a day-to-day evaluation of effectiveness of medical and bronchial hygiene pulmonary regimens. 4. And serve as an initial screening procedure. Available spirometric systems range from very simple screening devices to sensitive and accurate computerized programs that provide complete spirometric evaluation. The simplest screening devices have a bellows into which the patient forcefully exhales. A stylet moves across a graph paper and records the time volume relationship. Electronic spirometers have become very popular in the past decade. These have a range of features that include digital and direct readouts. These have a, a yes. Some provide graphic tracings of flow volume curves. Some recently developed computerized systems are available to provide very complete spirometric studies by use of the telephone. It should be emphasized that recently published articles have questioned the accuracy of some electronic units. It is the responsibility of the department offering the testing service to assure that performance characteristics of the unit being used are clearly defined and periodically checked. There is no question that the next decade will provide us with even more convenient and accurate spirometric studies. All right, moving on. We are at the top of page 68. Thank you for reading with us. Thank you. Oh, so good, right? Peace, highest, heart love. Thank you and love to my mods. Again, love to our families and friends. We're putting in the work here. Help everyone that we can. And this is a very big section. I want you to see it for yourself. Page 68, where we are going into clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So, the work of breathing. Yes, the work of breathing. Take notes. Here we go. Definitions. Work. Mechanical work is accomplished when a force moves an object to which it is applied. The quantification of that work will be the result of the force multiplied by the distance moved. Work equals force times distance. The spontaneous movement of air in and out of the lungs requires an expenditure of energy by the muscles of ventilation. The pulmonary pressures may be used as an expression of force, and the pulmonary volumes involved may be used as an expression of the distance. Thus, during steady state breathing conditions, the mechanical work involved may be computed in terms of the pressure times the changes in volume. Work equals pressure times volume. Power. Power is a term that refers to the rate at which work is being done. In clinical terms, the work of breathing actually refers to the power necessary to accomplish the ventilation, to move air in and out of the lungs. The muscles of ventilation must expend enough energy to overcome two major factors. One, the elastic recoil of lung and chest wall, and two, the frictional resistance to gas flow in the airways. For completeness, factors such as the frictional resistance in the movement of lung and chest wall tissues and the very low component of inertia must also be mentioned. Essential clinical factors. 4. Major clinical factors must be considered when assessing the work of breathing. 1. Compliance. 2. Resistance. 3. Active expiration. And 4. Ventilatory pattern. It would be a disservice to the reader if the impression were left that quantification of the work of breathing is simple and straightforward. If we consider the elastic recoil of the expiratory system as if it were a single entity exerted primarily by the lungs with some assist from the chest wall, the concepts become simple. The true interrelationship and complexities of these mechanical factors are fortunately of little clinical significance, especially when we are dealing with patients in respiratory distress and possibly in need of mechanical support of ventilation. Therefore, it is clinically acceptable to view these factors in their simplistic relationships. Compliance. The process of moving gas into the lungs requires energy to overcome the elastic recoil properties of the lung and chest wall. It should be obvious that part of the energy expended for inspiration is stored in the elastic tissues of the chest and thorax as elastic recoil energy. This energy is normally used to provide most of the work of expiration. In normal breathing at basal conditions, expiration is referred to as passive because it does not require active muscular work. The lower the compliance, the greater the elastic recoil energy available for expiration. More importantly, the lower the compliance, the greater will be the energy expended to provide a deeper inspiration. Yes, clinical. Oh my goodness. That makes all the sense in the world. Thank you so much for subbing. We are putting our friends and family in doctor, in master level information with this. Thank you so much. And remember, earlier we were talking about the last chapter with compliance. It's how much the elasticity allows it to come back to its normal place. So when we're looking at the lungs, it's in one state and then it's expanding, right, with the inspiration. And it's expanding out. Now, how much it recoils is how much that the inspiration, change the actual surface to content. So it says again, more importantly, the lower the compliance, the greater will be the energy expended to provide a deeper inspiration. Yes! I know, so we can help others. That's what we're about. We're the healers and light workers of the world. It's for us, it's our onus to put this information out there since we have it to help others, right? Thank you so much. Thank you so much. Highest heart love. Okay, so resistance. Resistance. At the end of shallow inspiration, intrathoracic airways may remain narrower and therefore cause a greater resistance to gas flow than they normally would. To overcome this potentially increased airway resistance and increased expenditure of energy may be needed active exhalation during expiration. This increased expiratory energy can be reduced by deeper inspirations that allow less resistance and a greater degree of elastic recoil during expiration. This generally indicates that the shallow breathing at a rapid rate demands a greater energy expenditure to overcome airway resistances than deep and slow breathing. Now, I have to make this so we can understand it easier, right? Thank you so much, Thanos. Highest heart love. So, when we learn to stay underwater longer, right, they teach us to hyperventilate first. You're creating a lot of work and friction and expanding in a fast rate. So this allows us to fill up all the different air pockets to be able to use and store. Right? Makes sense. Active expiration. Thus far, our discussion has assumed that expiration is entirely passive. As pointed out previously, this is the case in normal, resting ventilation. In fact, in healthy people, expiration is almost totally passive, even with minute volumes as high as 20 liters per minute. However, for for Every high minute volumes in patients with healthy lungs and for normal minute volumes in patients with diseased lungs. The expiratory muscles may be brought into play. That work must also be included in a total assessment of the work of breathing. Peace and ooh, highest heart love. Thank you to all peace and highest heart love to all the wonderful beings out there taking part and knowing this 8-8 is here for us. So we're doing what we need to do. Happy Friday. Full moon energy. Oh goodness, we're doing it's so beautiful. Right? Peace, Queen Bee. Highest heart love. Ventilatory pattern. If a constant minute volume is maintained, the work necessary to overcome elastic recoil is increased when breathing is deep and slow. On the other hand, the work expended to overcome airway resistance is increased when breathing is rapid and shallow. If we plot total work against ventilatory frequency, we see that there is an optimal ventilatory frequency at which the total work of breathing is minimal. Many investigators have noticed that human subjects and animals tend to select ventilatory frequencies that correspond very closely to calculated frequencies for minimum work. Ding! That's a big one right there. For all of you taking notes for the MCAT and just for the self knowledge. That's why I read these books because we master ourselves here, right? For self information, for self wisdom and knowledge and understanding of how organisms and other animals work. I'll read that again. That's very key. It says many investigators have noted that human subjects and animals tend to select ventilatory frequencies that correspond very closely to calculated frequencies for minimum work. Wow, this goes back to animal speak, right? Self preservation. The cells want to stay alive. We want to do things with the least resistance naturally, especially breathing, right? Thanos, Thanos highest heart love, man. You're so cool. Thank you so much for being here, man. Much love. This response has also been well documented in patients with diseased pulmonary systems. When compliance is decreased, ventilatory frequency increases and tidal volumes decrease. When airway resistance increases, the ventilatory frequency decreases and the tidal volume increases. This is objective testimony to the clinical statement that the ventilatory pattern present in a diseased patient is determined almost entirely by minimal expenditure of energy rather than by efficient physiologic ventilation. The ventilatory pattern chosen by a physiologically stressed patient must never be assumed to be advantageous in terms of molecular gas exchange. Rather, it should be assumed to be the pattern requiring the least expenditure of energy for that minute ventilation. And here I'll show you figure 3.8 with normal compliance and decreased compliance. This is very key. Page 70. We look at us just moving on. Figure 3.8 says decreased compliance and normal compliance, units of work, breathing, and frequency. Okay. Thank you so much for reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition, 1979. All right, it says 3.8. A is a graphic representation of total work of breathing when minute ventilation is unchanged, but ventilatory pattern, tidal volume, and frequency is varied. Note that for any minute ventilation, there is a ventilatory pattern that requires minimal work. Of course, total work is the summation of resistance work, air waves, and elastic work, lung parenchymal and chest wall recoil forces. If compliance is decreased, as in B, the graph shows that the pattern of ventilation at which the minute volume can be achieved with minimal work is dramatically altered. This is a schematic representation of the principle that work of breathing is the major factor determining ventilatory pattern. And we just read that in the text. All right. Ventilatory reserve. This is so powerful. This is what we're talking about. When we're dealing with reserve ventilatory energy, this is what's left after you expel the air, right? Oh my goodness. Highest heart love can see. Peace can see. Highest heart love. Sending love to your family and the dog. How's everything? Yeah, we've been sending love to our family too. It's the 8-8 portal. Today is my nephew's birthday. So proud of him. So proud. Yeah. Highest heart love to all our family and friends. All right. We'll read this last part at page 71 and then we'll give a break for it. Thank you so much, Thanos. Thank you so much. He said happy birthday to Jeremiah. Thank you so much. Much love and much appreciation for being here. All right. A classic description of a healthy resting adult denotes an oxygen consumption of approximately 250 milliliters per minute. Oxygen consumption for the work of breathing is less than 5% of the total. Even under these excellent physiologic conditions, the efficiency with which the energy is utilized for the actual mechanical aspects of ventilation is astoundingly poor. In the resting state, about 90% of the energy expended for the work of breathing is lost as heat within the ventilatory muscles. This means that only 10% of the energy is used for moving gas in and out of the lungs. The efficiency is further reduced in the presence of pulmonary disease and with increased minute ventilation. In severe disease states, the system may become so inefficient that any oxygen potentially gained from increased ventilation is completely consumed by the increased muscular work. This may progress to the point where an increase in ventilation results in net oxygen loss to the organism. In this circumstance, the alveolar gas improvement that can be accomplished by increased spontaneous ventilation is greatly limited. It is important to note that for a patient being mechanically ventilated, the situation just described would not be true. The increased work in this case would be provided by the apparatus rather than the ventilatory muscles. The limitation of active ventilatory efficiency is only reached at very high minute volumes in healthy patients. However, in the presence of significant disease, the efficiency level may be so low as to impose severe limitations to even minor degrees of physiologic stress. In respiratory care, we are consistently confronted with the potential problem of the patient who may become unable to maintain adequate ventilation or meet increased physiologic stress. And appreciation of the fatigue process is so vitally important to the clinical support of the pulmonary system that an attempt must be made to assess the work of breathing and the reserves available to meet physiologic stress. Despite the difficulties and numerous complexities that have been elaborated here, clinical guidelines for asserting ventilatory reserve have been developed. The guidelines are based on functional concepts and clinical realities of the work of breathing. The following concept produces obtainable, reproducible, and reliable information that can be applied in the clinical circumstance of supporting gas exchange in the critically ill patient. Of the body's total oxygen consumption, the percentage that is used by the ventilatory muscles can be considered a reflection of the work of breathing. If this is so, then the relationship depicted in figure 39a exists. As minute volume is increased, the percentage of the total oxygen consumption that is used for breathing is increased exponentially. In other words, in the normal resting state, a person uses approximately 5% of his total oxygen consumption for ventilatory muscular work. As the person increases mechanical ventilation, he must use more muscular power. The increased muscular work demands increased oxygen consumption, and so the amount of total oxygen consumption that is used for the work of breathing increases. As a matter of fact, this increase in oxygen consumption is not linear. Therefore, not only the amount, but the percentage of total oxygen consumption applied to the work of breathing increases. Woo! Oh my goodness, this is so good. I love dealing with positive correlations. Oh my goodness. That's right. So basically, work out on your will, increase your oxygen consumption. Yes, Thanos. Thank you for dropping that in the chat. That's right. Thank you so much. Highest heart love. Exactly. Well said. Thank you, Kenzie. Thank you so much for the love and happy birthday wishes to my nephew, too. Thank you. I will make sure that he receives all this love and watches this as well to see. Thank you so much. Exactly, Thanos. Exactly. The untrained person has experienced this after running for a period of time. The work of breathing becomes so demanding that he must stop and, for a short period of time, concentrate on doing enough ventilatory muscular work to repay his oxygen debt. See, this is all talking about this section right here, ventilatory reserve. when we're out of breath. That's what I had put down here at the bottom. I'm writing with both hands, and a lot of times, no, like 99% of times, I'm writing in my left with when I'm underlining, and I put down there at the bottom, out of breath. This is how we also distinguish the VO2 max, right? This is all detailing it step by step. Thank you so much for reading these masterful books with us. That's what we do in peace. You know, we can do the most amazing things in peace. Yeah. So I'll read that again. The increased muscular work demands increased oxygen consumption, and so the amount of total oxygen consumption that is used for the work of breathing increases. As a matter of fact, this increase in oxygen consumption is not linear. Therefore, not only the amount but the percentage of total oxygen consumption applied to the work of breathing increases. The untrained person has experienced this after running for a period of time. The work of breathing becomes so demanding that he must stop for a short period of time, concentrate on doing enough ventilatory muscular work to repay his oxygen debt. Increasing minute ventilation causes an exponential increase in ventilatory oxygen consumption. If we add airway resistance, such as results from obstructive lung disease, the curve looks much like the dotted line in Figure 39A. The work of breathing is far greater at the resting stage, and the increase in the percentage of oxygen consumption is far greater when there is increased airway resistance to overcome. Figure 39b shows the same curve plotted as a function of the vital capacity, i.e., the curve represents the ventilatory work as a function of the portion of the vital capacity being used as tidal volume. Suppose for example, that a man with a vital capacity of 5,000 milliliters has a tidal volume of 500 milliliters. He is using 10% of his vital capacity as tidal volume. The percentage of oxygen consumption being used for breathing is low. A second man has a vital capacity of only 1,000 milliliters, but must maintain the same 500 milliliter tidal volume as the first man. He is using 50% of his vital capacity and is consuming far more oxygen for breathing than the first man. It is important to note that even though the tidal volumes of both men are the same and the total body oxygen consumptions are the same, the percentage of oxygen consumed for the work of breathing is much higher for the second man. In such an example, the second man has far less capability to increase his ventilation to meet stress. Because of his greatly diminished reserve, it is far more costly for him to increase his ventilatory work. The greater the portion of the vital capacity that is being used for a tidal volume, the less the ability of the patient to increase his tidal volume to meet a stressful situation. Therefore, vital capacity can be used as a gross indicator of ventilatory reserve. Obviously, the degree of airway resistance must always be included in such an assessment. Even though this is a greatly simplified and scientifically imprecise reflection of ventilatory reserve, it is a very useful clinical concept since vital capacity and tidal volume are easily measured at the bedside. This concept of ventilatory reserve is basic to the understanding of clinical supportive measures for pulmonary disease, and it also plays an extremely important role in the predictable insult to the pulmonary system by surgical and anesthetic stress. Anesthetic stress. We'll pause right here. Continue back with clinical application of respiratory care. And here's that figure on the last page. It's figure 3.9 showing the graph. Okay. Graph A and graph B. Thank you for reading Clinical Application of Respiratory Care by Barry A. Shapiro and Ronald A. Harrison, Carole A. Trout on this 8-8 Lions portal, and wishing you all highest heart love and honor. Thank you so much. It says the graphs. Here we go on page 73. It says percent of oxygen consumption for breathing, and it shows as it's gradually going up at 20% and at 5% at 5 milliliters. And then on the second one, on B, it says percent of oxygen consumption for breathing, and it shows at 5% A and B on the same line from 10% to 50% to 100%. So this is the minute volume down here, B. Thank you so much for reading with us. What a beautiful, beautiful, outstanding information. Wishing all of you highest heart love. And this line portals, that's right. We want to keep our head nice and clear, just like our breath. Love you so much. Thank you for all the peace. Love to all the light workers. We are here for the people, giving out the information for free. Thank you so much for anyone that has donated, whether it be recycling or monetary. I have so much love and respect for you. Thank you so much for devoting and using your time to read about the self, mastering thyself. Here's a drink of love water to all my friends and family. To Jeremiah, I love you. To my beloved friends and my highest heart love, thank you so much. I love you. Happy Friday. I want you to have a wonderful day. We celebrated yesterday my dad's 70th solar return. We drink love water to all of you. Thank you so much, Thanos, for being here. Highest heart love. Yes, this is a $3,500 book. And that's why I was like, man, I'm bringing it to the people. We must be able to heal ourselves. We must be able to continue to master ourselves. And that comes with showing love to one another. This is that corner of YouTube where we sit in peace and we vibe off one another. We encourage one another. We uplift one another. So, highest heart love. Thank you so much for this reading. Peace, peace. Yes, Tupac. Much love to all my family. 3,500. I know is so true. Yeah, but we manifested this together. That's what being the light workers we've come to do, so we can give this service, you know, more backing. So, I love you. I love you. Peace, peace. I will see you soon. Love to all of you.